It's also in presentation mode. Oh, there. Oh, now it's advancing.
There you go.
Yeah, but that's not in the slideshow mode. But I can do the presentation from this mode. That'll be fine. So you can see the slides now?
Yes.
Okay. So the one I was talking about here is the schematic diagram of the placenta here. So baby is up here at the top. These are the maternal arteries going into the placenta. This is the villus tree. This is the fetal surface of the placenta. This would be the maternal surface of the placenta. So two of the major lesions we see are malperfusion lesions, where the maternal vascular supply to the intervillus space is impaired. We call that maternal vascular malperfusion. From the other side, when we have obstruction, usually in the umbilical cord, but sometimes from thrombi within the placenta, we have what's called fetal vascular malperfusion. And then we have processes that can affect the large fetal vessels in the chorionic plate and in the umbilical cord, and that's chorioamnionitis with a severe fetal inflammatory response, and sometimes prolonged meconium exposure. Parenchymal lesions include chronic villitis, which is defined as a maternal anti-fetal rejection type response, which leads to lymphocytes within the placenta of maternal origin. It's like a graft rejection kind of phenomena, quite surprisingly common. Delayed villus maturation, where the placenta doesn't develop appropriately and the morphology is more like a preterm placenta. And then finally, lesions where we have premature separation of the placenta from the underlying musculature. And that can either be due to arterial disruption, in which case you get an abruptio placenta, which is a sentinel event, or it can be a marginal abruption where just a part of the placenta is detached from its underlying blood supply. So there are several main mechanisms of CNS injury. And these I discuss in more detail in a review that appeared I guess it's this year, in Experimental Neurology. If you want to read more about this, this is the reference. An old mechanism has been called paucity of protection. We don't really see pathologic lesions, but it's been invoked to explain why preterm deliveries can lead to increased CNS susceptibility to injury, because factors that are usually delivered from the placenta as you go from 24 weeks to term are no longer present. And so you get secondary micronutrient deficiencies, which affect CNS development. Another major one we all know about are sentinel events, where the major supply lines to the placenta interrupted. So that would be the arterial supply from the mother, the fetal supply from the umbilical cord, loss of circulating volume from fetal-maternal hemorrhage. Those are some of the main ones, or a tear in the umbilical cord. And then I'll spend some time on these critical lesions or central pathways, which are most commonly seen and associated with CNS injury. Multiple placental lesions can sometimes interrupt compensatory pathways. So, you can usually adapt to the loss of, some, say, maternal vascular perfusion, but then if you also interrupt the fetal vascular perfusion, you have a synergistic effect of those two processes rather than simply an additive effect. And then there's a broad group of placental lesions that can decrease the normal placental reserve. It's said that most placentas have about a 30% reserve capacity. So you can cut away 30% of the parenchyma in an experimental system like the sheep placenta, and the fetus is not disturbed in any way. So CNS susceptibility, so another factor other than just the placenta lesions is the resiliency of the fetus to placental insult. And I'm not going to talk too much about that, but clearly there are individual differences in the susceptibility of the CNS to injury. Some of them are the result of developmental stage or early gestational age. They may relate to fetal genetic background, although we don't really understand too much about that. There are pre-existing CNS abnormalities, some things like intraventricular hemorrhage or white matter damage unrelated to placental processes that may mimic a placental process. And then we'll talk a little bit about altered fetal physiology when it's secondary to placental processes, and a little bit about preconditioning, where an early event may decrease the threshold for injury of a later event. So starting right out with preconditioning, these are data from experimental models, sheep and mice, but as I'll show you, there's some evidence that they apply to humans as well. And the concept is that you have a first hit, which reduces a threshold to the second hit. The first hit is days to weeks before the second hit. They overlap in terms of their nature, LPS or cytokines, hypoxia and ischemia, stress and excess glucocorticoids, and often the second hit is one, either the same hit or something in the same family. So the first part of the talk, I'm going to talk about CNS injury in preterm infants, and there's sort of a broad consensus that the lower the gestational age, the higher the incidence of CNS injury, an increase in underlying susceptibility. Almost any kind of an infection has been associated during pregnancy, has been associated with CNS injury. This includes maternal infections like acute appendicitis, placental infections like acute chorioamnionitis, or fetal infections like a torch infection, say. Clearly, especially in the neonatal intensive care unit, abnormalities, gross abnormalities in cardiopulmonary function are going to decrease the threshold for CNS injury, hypotension, acidemia, alterations in PO2 and PCO2, with PCO2 either decreased or increased CO2 are risk factors, and then underlying chronic lung disease. And then finally, as I mentioned before, there can be superimposed structural brain lesions that combine with more subtle microscopic processes, things like intraventricular hemorrhage and white matter damage. So the first study that I'm going to show you is studies that I initiated shortly after I came back to university hospitals after doing my fellowship in Boston. And this took advantage of Maureen Hack's cohort of preterm infants that she had been following for many years. In this case, they were very low birth weight infants, so less than 1.5 kilograms. The case has been collected over a time period in the 80s. We began looking at them in the mid-90s and published the results in 3 papers toward the end of the 90s and in 2000. So it's basically the inborn very low birth weight population, total live births over 1,000, 80% survived to 20 months, at which time they were tested, 93% follow-up rate, 6% had cerebral palsy, and 3% had other fixed motor disorders related to cerebral palsy. And these are some of the clinical findings that were associated with neurologic impairment in these cases. So we had, and so here we're only looking at the infants where the placentas were available for examination. So severe cranial ultrasound abnormalities, underlying chronic lung disease, clinical acute chorioamnionitis were all significantly associated with CNS damage. Hyperbilirubinemia and documented sepsis, some had borderline associations. And here we turn to the same cases. I'm looking at the placenta, and we were surprised to find that severe villus edema, which was not exactly a respectable placental lesion at that point. There had been some anecdotal articles associating it with lung injury in the past, but most serious placental pathologists didn't even think it was a lesion. But we found it to persistently be the strongest predictor of neurologic abnormalities in the preterm population. So something's going on there, whether it's intrinsically placental or whether it reflects some process going on in the fetus that you just see in the placenta is not entirely clear. And then the other lesions are related to chorioamnionitis, either chorioamnionitis with a very high-grade fetal inflammatory response seen in the large fetal vessels of the placenta, or chorioamnionitis with a fetal inflammatory response and superimposed thrombosis in those vessels, usually in the chorionic plate. The thrombi being borderline significant, the high-grade fetal inflammatory response not quite reaching significance. Many studies with a variety of adverse outcomes have found that multiple placental lesions affecting different placental compartments are a very strong predictor of neurologic injury and other types of altered fetal physiology. And we found that as well. That actually had the highest odds ratio for CNS injury. So fetal inflammatory response is, we and others have found this to be associated with neurologic injury. The bulk of the defense against infection is in the placenta, in the membranes, and it's been forms of damage that are non-infectious. With chorioamnionitis, and we find a significant association between the bacterial load, as mentioned, as measured by 16S RNA by PCR, quantitative PCR, and elevations in cytokines. So it seems like, at least in most cases, especially in preterm infants, it's the magnitude of the bacterial load in the placenta that determines the level of cytokines in the fetus. There is a placental histologic marker as well, and that is that when you have inflammation that affects the umbilical artery, so-called phoenocytis, but specifically the arteries as opposed to just the vein, this predicts increased circulating levels of cytokines in the fetal cord blood, both IL-6 and IL-8, and this has been reported by a couple of different investigators. We did a sort of path analysis because we thought that some of the clinical findings associated with CNS abnormalities in this population might be due to previous placental processes. And we found, first of all, that clinical and histologic chorioamnionitis are very strongly correlated with one another, but they don't always go together. Histologic chorioamnionitis is much more sensitive in detecting chorioamnionitis than a clinical diagnosis. The clinical diagnosis usually reflects some cytokines in the mother, and so it's actually associated with villus edema in the placenta. And villus edema is a predictor of severe ultrasound abnormalities like intraventricular hemorrhage and white matter damage, and also a borderline significant predictor of chronic lung disease. So the clinical chorioamnionitis and cytokine seems to work through this kind of a pathway, whereas the histologic chorioamnionitis, as I suggested in my previous slide, works through actual thrombosis, and that can lead to thromboembolism in the baby, or it can just lead to a coagulopathy or a consumptive coagulopathy or alteration in the coagulation system in the fetal circulation. And then independent of all of these other things is multiple placental lesions, which doesn't really interact with any of the clinical factors, and is, when you combine all of these, a very strong predictor of neurodisability. So the second group of, the second study that we published is a different cohort. So also from Maureen Hack's long-term follow-up study, but in this case, we're looking at extremely low birth weight infants, so less than 1 kilogram, and we're following them at a much later age, so at 8 years old. And this is a somewhat later group. They were all admitted in the early 90s, or initially delivered in the early 90s. So similar to the previous cohort, we had 218 inborns, 76% survived the neonatal period, 92% had neurocognitive testing at 8 years of age, and whether they had cerebral palsy was also ascertained at that time. 85% placental submission to pathology. So our end population was 129 8-year-old children with placental pathology, and we published this in 2007 in Pediatric and Developmental Pathology. So first, just looking at cerebral palsy at 8 years of age, we found that actually maternal vascular underperfusion, so preeclampsia-like pathology, was the strongest predictor of cerebral palsy. So the actual arteriopathy, which underlies the diagnosis of preeclampsia and maternal vascular malperfusion, and then the secondary accelerated villus maturation that you see with maternal vascular underperfusion were all strongly associated with cerebral palsy, whereas fetal vascular lesions and infections were not. The neurocognitive tests that were used in this study were the NEPSI, which, I don't know a whole lot about myself. It purportedly is a measure of executive function and memory, and the Kaufman Assessment Battery for Children, which is more of a measure of global mental processing skills. So first, looking at the NEPSI test, and here we're looking at scores that are more than 2 standard deviations below the normative mean. And again, we find that severe maternal vascular malperfusion, in this case multiple villus infarcts, was a significant predictor of abnormal NEPSI scores. But we also see that the severe villus edema that we saw in the previous study is also a significant predictor of these neurocognitive abnormalities. Still, the inflammatory markers by themselves are not significantly associated. Looking at the KABC, we don't see an association with maternal vascular disease, but the edema again stands out as a strong predictor. While acute chorioamnionitis and the fetal inflammatory response by itself didn't turn out to be associated with abnormal neurocognitive testing, we did find that when you looked at the intensity of the fetal inflammatory response, that when you had a high intensity fetal inflammatory response as opposed to just a low intensity fetal inflammatory response, there was a significant decrease or a significant change in low NEPSI scores with the high grade inflammation and a borderline decrease in KABC score. And you can see that most fetal inflammatory responses are low grade, so you can see why the overall measurement of acute chorioamnionitis with the fetal inflammatory response didn't detect an abnormality that we were able to see when we broke down the histology by grade. And then to just wind up what I wanted to say about preterm infants, most of you have probably heard of the Elgin Study, which was conducted in the early 2000s. PI Alan Leviton, who was at Children's Hospital in Boston, a multi-center study of 14 hospitals, 1,200 extremely low birth weight survivors, 805 with placental pathology. So a much larger multi-center study, and they found overlapping findings with 4 outcomes in this case at 10 years of age. They found that cerebral palsy was predicted by high intense chorioamnionitis, either intense maternal inflammatory response or an intense fetal inflammatory response. Seizure disorders, again, also chorioamnionitis being the main. Chorioamnionitis was the main histologic variable assessed in this study, and also a significant association with autism. They were not able to find any associations with cognitive impairment, but I'm not sure that they looked at the same variables that we did in our study. And this was reviewed in American Journal of Obstetrics and Gynecology a couple of years ago. So now I want to turn to CNS injury in term and near-term infants. Again, going through the background and what's sort of commonly accepted in the literature, there is an unclear association with birth asphyxia. Some would say it's frequent, some would say that it's rare, but clearly there are infants with so-called hypoxic ischemic encephalopathy, acidosis, and low APGAR scores who develop cerebral palsy and other forms of CNS injury. Then neonatal encephalopathy, which is basically just abnormal CNS status at birth, without any comment as to the long-term sequelae. Fetal growth restriction increases the risk of CNS injury. Again, any kind of inflammation, maternal, placental, or fetal, Hypercoagulability, patients with coagulation factor abnormalities, protein C, protein S deficiency, and there is a strong familial component to CNS injury, especially in term infants, not so well studied in preterm infants where there are many more variables. So in considering what the differential diagnosis of so-called birth asphyxia might be, I mean, obviously acute sentinel events that lead to acute hypoxia, as I said before, cord prolapse, uterine rupture, fetal hemorrhage are certainly one possibility. Another possibility is that the symptoms simply reflect some kind of other pre-existing fetal CNS damage. And so the damage is remote, but the symptomatology is mimicking some kind of an acute event. But the hypothesis that we favor for most cases is, again, a preconditioning kind of response where you have acute stress superimposed on underlying pathology, and that underlying pathology may be decreased placental reserve, or it may be some discrete lesion caused by a more episodic process, and that this then decreases the threshold for injury when you have something acute happening at the time of delivery. So this is the hypothesis, is that underlying risk may be increased in these cases, but that they may have a combination of chronic placental lesions, subacute placental lesions, and acute lesions, but these all interact with one another and synergize to cause an increase in neonatal complications and long-term adverse outcomes. So the remote antenatal factors we're talking about are placental lesions that are present for more than 1 week prior to delivery. The chronic underperfusion of the intravillus space, maternal vascular malperfusion, chronic underperfusion of the villus tree, fetal vascular malperfusion, the sort of rejection type, transplant rejection type response, the chronic villitis, and then another lesion, massive perivillus fibrinoid deposition, which is rare but extremely serious, where essentially the entire intervillus space clots off. Examples of some recent antenatal factors, 6 to 12 hours to 1 week prior to delivery, is the fetal inflammatory response in acute chorioamnionitis, which is more in the 6 to 12 hour range. Prolonged meconium-associated lesions where you get fetal vascular injury in the large vessels of the chorionic plate. And then evolving maternal ischemic or fetal ischemic lesions, so very recent villus infarcts and just very recent karyorrhexis of the tissues that are dependent on the fetal vascular perfusion. And then finally, you have your sentinel events, which can be serious, like abruptio placenta, uterine rupture, cord prolapse, or fetal maternal hemorrhage, or it can be more subtle, just prolonged uterine contractions and the kind of monitoring abnormalities that in a completely normal host wouldn't cause CNS injury. So the third study I want to talk about is an early study we did in a bunch of medical legal consults. So medical legal consults are an interesting population. You have a lot of history. Attorneys, when you do a medical legal consultation, give you all the history you need. You're pretty sure of the outcome because there's usually multiple neurology and neonatology consults, so they're pretty well documented in terms of what the final CNS status is. And you can see a lot of them if you do it for a long enough time. So at this point, I took 40 medical legal consults at greater than 37 weeks with documented neurologic impairment. The problem, of course, is the control group. It can't be a true control. It has to be a comparison. And you're limited to placentas that you have that were sent to pathology for some other reason. And so in order to sort of limit it, meconium stained fluid is a common indication for sending a placenta, but it really doesn't have by itself much of an association with placental pathology, especially at term. So we picked 174 consecutive cases with nothing other than meconium stained fluid as our comparison group. And so these were the lesions that were associated with neurologic impairment in term infants. The chronic lesions were a high-grade chronic villitis, that rejection type response, high-grade fetal vascular malperfusion, the fetal thrombotic process due to decreased perfusion of the villi, and the massive perivillus fibrin, which is rare but strongly associated with adverse outcomes. The subacute processes were, again, acute chorioamnionitis with a high-grade fetal inflammatory response, similar to our preterm result, meconium-associated vascular necrosis due to prolonged meconium exposure, thrombi in the fetal vessels, and then an increase in circulating nucleated red blood cells, which is generally assumed to reflect hypoxemia of at least 12 to 24 hours duration, although exactly how long you have to have hypoxia to get increased nucleated red blood cells is somewhat controversial. So one of the things we did was that we simply looked at the total number of significant abnormalities as a predictor of cerebral palsy in this population. And you can see that having any one of the significant predictors captures a large number of the cases. Almost 90% of the cases had at least one of those abnormalities, but it's not very specific. So many of the control cases also have such a process. But as you get multiple lesions, you can see that the sensitivity doesn't go down that rapidly. So you're still capturing over 60% of the cases with 2 significant lesions, and your specificity is much higher. So it's a pretty good lab test for cerebral palsy, seeing how many placental abnormalities you have. Then we went on to look at the timing. And so obviously there aren't that many cases that have multiple chronic, multiple subacute, or subacute superimposed on chronic. So these odds ratios, the confidence intervals are very wide. But multiple lesions that occur at different times did have the highest percentage of cases and the highest odds ratio for predicting neurologic impairment. Now, you may have noticed that several of the processes in term infants that predict abnormal neurologic outcome affect the large fetal vessels of the placenta. So we wanted to cone in on those and look at exclusively at severe fetal placental vascular lesions and their association with neurologic impairment at term. And at this point, we had more cases to look at, 125, and they broke down like this. 22% had cerebral palsy without preceding neonatal encephalopathy. 11% died at less than 24 hours with neonatal encephalopathy. 29% had neonatal encephalopathy with subsequent cerebral palsy, and 18% had other CNS abnormalities that were not classically cerebral palsy. So it was a heterogeneous group of neurologic impairment at term. And we published this. Our comparison group was, we didn't look at meconium stained placentas in this case. We simply compared them to 250 consecutively examined placentas at more than 36 weeks with complete clinical history in the same time period. And this was published in the American Journal of Obstetrics and Gynecology in 2005. So these were the overall results. And for all of the 4 categories of severe vascular lesions, fetal vascular malperfusion, chronic villitis with involvement of large fetal vessels, acute chorioamnionitis with a high-grade fetal inflammatory response, and meconium with necrosis of the chorionic plate vessels, it was the high-grade response that was significant, whereas the low-grade response was either borderline significant or not significant at all. And interestingly, one or more of the high-grade lesions was present in more than half of the cases. So it seems like there are several placental processes that are associated with neurologic injury, but particularly those that involve large fetal vessels are important. And why is that so? Well, I think the reason that it's so is because the placenta is simply a fetal organ. So you can just tie it into the rest of the circulatory system. And those large fetal vessels are really major regulators of flow in and out of the placenta. And they're conduits for placental mediators to get into the fetal circulation. And not only that, but if you do have thrombi in the placenta, they can embolize through the foramen ovale and into the cerebral circulation. So we listed some of the reasons why these large fetal vessel lesions might be more associated with the CNS abnormalities. I mentioned direct communication, umbilical venous obstruction acutely depriving the fetus of oxygenated placental blood. The fact there are only 8 or 10 of these major chorionic arteries, and they transmit almost half of the total fetal cardiac output. They are end vessels. They don't anastomose with one another. Each chorionic artery is the sole supply to a large region of the placenta. Prolonged malperfusion leads to involution of the dependent capillary bed. So once you block off one of those large vessels, it can't come back again because all of the smaller capillaries disappear. We get avascular villi. And there's no maternal vasoregulation. So once you shut off the maternal perfusion, the fetal, once you shut off the fetal perfusion, the maternal perfusion continues to that region. So it's just like VQ mismatching in the lung. So your efficiency of your placental efficiency goes way down. And so severe fetal vascular lesions, you can have occlusion leading to hypoxemia and other major circulatory problems. You have thrombi that develop in these lesions. They can embolize or lead to a consumptive coagulopathy or platelet activation. Particularly in chorioamnionitis and transplant rejection, you get inflammatory mediators, which can damage the endothelial glial neuronal unit. There are a lot of cytokines, reactive oxygen intermediates, activated complement components, and the list is long. And even without classical inflammation, just tissue necrosis in the placenta can activate mediators through damage-associated molecular patterns, heat shock proteins, urate, hyaluron, nucleotides, etc. So the final is, well, I'm going to show you another study of neonatal encephalopathy, but the final study that we did with with cases from university hospitals is really more of a review. So at this point, we have done far more medical legal case reviews, and these were all cases of cerebral palsy in term infants. All with strictly defined cerebral palsy, singleton births greater than 36 weeks. And we published this sort of review of our experience in 2008 in Pediatric and Developmental Pathology. And we utilized a hierarchical classification. So sentinel events, when they were present, were considered to be the cause of underlying CNS injury, irregardless of what else was there. Severe fetal placental lesions, and as I've argued, were the most severe group of placental lesions that we saw. But then there were other subacute and chronic placental dysfunctions, which decrease placental reserve, and then some placental lesions which are suggestive of adaptation to hypoxia, like increased circulating nucleated red blood cells, or an increase in villus capillaries, which I haven't mentioned before. And then finally, there are those placentas where we didn't see anything and there's no apparent placental explanation for neurologic dysfunction. So 20% of the cases in the review had an identified sentinel event, and these are the sentinel events that we included. 34% had one or more severe fetal placental vascular lesions, the most common of which, surprisingly, was meconium-associated vascular necrosis, which is actually a quite rare lesion. We only see it maybe once a month in our populations that we see here at university hospitals. It's not common at all. Subacute or chronic placental lesions, another 23%. Maternal vascular malperfusion. This is a low-grade fetal vascular malperfusion, the fibrin, the transplant rejection. This is a chronic abruption, and this is the delayed villus maturation I pointed out in the first slide. And then the adaptation to hypoxia, increased nucleated red blood cells, chorangiosis, or an increase in placental capillaries without any other lesion, 15%. And when we went through this hierarchy, only 8% of cases were completely unexplained by the placenta. And so we combine this into sort of an algorithm when we review placentas for medical, legal, or QA purposes. If we see a sentinel event, we consider that to be first priority for placental causation of injury. When we see a severe fetal placental lesion, that would be second priority. as a placental causation. And then this group of lesions here, chronic lesions, subacute lesions, and adaptation to hypoxia. If it's high grade or there's more than one of these, we consider this to be a potential cause, or third priority. And then if none of those things are present, we make a judgment of no definitive placental role in the adverse outcome. And I just wanted to summarize. So we went on to look at a few more cases after we published that review. The end, by the time I stopped reviewing medical legal cases after a long, painful period, was 205 cases. And in the meantime, we had started a placental database here at university hospitals. It was a 10-year database of all of the placentas that we had looked at that time, over 5,000 of them from term births with complete information, clinical and pathologic. So it was at least a larger comparison population, although again, not the same cohort, and many of them placenta sent to pathology for other reasons. And this was the final tally. Increased nucleated red blood cells were the most common process. Fetal vascular malperfusion, low grade, and meconium-associated vascular changes were the most common. And then all the ones that are highlighted in red are ones that are more than twofold elevated in the CP group as compared to the comparison database. It pretty much reflects what I've shown you before. It's just more cases. So the final thing I wanted to show you is another study, which was done much later, and we published this in 2018 with some collaborators from Norway and Montreal. And the placentas were all from a single hospital in Montreal, where they did pathology on every single placenta. So in this case, we did have a true control group. The outcome was neonatal encephalopathy. And the placentas were available on 84% of the cases with neonatal encephalopathy and 97% of the controls. So theoretically, all were submitted, but there were some that were missing. We once again saw that fetal vascular malperfusion on fetal side of the placenta was the only major predictor of adverse outcome, in this case, neonatal encephalopathy. So we distinguish two different types of fetal vascular malperfusion. One is kind of a global malperfusion due to umbilical cord occlusion, and I won't go through the pathologic defects. And the other is what we call segmental, which is associated with thrombi in individual chorionic vessels. And this can also be due to chronic umbilical cord obstruction, but it's more segmental and affects just a part of the placenta. And what we found, it was the umbilical cord, the global fetal vascular malperfusion, which was more strongly associated with neonatal encephalopathy. There was a borderline, depending on how you interpret the numbers, association of segmental fetal vascular malperfusion, and segmental fetal vascular malperfusion is less common. So I think that, I think fetal vascular malperfusion by itself is important. And in this case, we didn't have that many cases, but of high grade, but the ones that were high grade, it was, even with such a small number, there was still a borderline association with neonatal encephalopathy. So a conclusion was that global was at least as important as segmental and thrombi, so umbilical cord, chronic umbilical cord occlusion, as basically measured by the finding of avascular villi, scattered avascular villi in the placenta. Fairly subtle histologic finding, but important. And then high grade is simply by the number of avascular villi. So if there's an average of more than 30 per slide, we call it high grade. This didn't reach technically statistical significance and was just actually presented in the paper as a supplemental table, but it does go along with our previous observations that the duration of meconium exposure is also associated with the prevalence of neonatal encephalopathy. So when you only have meconium in the membranes, which is usually from recent meconium exposure, there was no association with neonatal encephalopathy. When you had macrophages that were were throughout the chorionic plate, but there was no necrosis of the vessels. There was a trend toward an association with neonatal encephalopathy. But when you had actual necrosis of the vessels, which was again quite rare in this population, it still achieved borderline significance. And then finally, I just wanted to go over some of the, I've presented our results, and we've had a number of studies, but there are many others who've done similar studies in the literature. And I'm doing it by placental lesions. So chronic villitis, that sort of rejection response where you have maternal T cells attacking the villi. A couple of pathologists, Marjorie Grafe and Linda Ernst, found that to be associated with neuronal necrosis in IUFD. Compared to controls. Owen Mooney found an increase of neonatal encephalopathy, as we did. And Sarah Johnson actually found that this identified this subgroup that was resistant to head cooling. And we have some similar data that we've published with Yvonne Wu in San Francisco, data that I didn't show you because it was based on histology reviews that were done by other people, even though we did the final analysis of the data, but I haven't actually seen the slides. And then finally, Peter Nichols, associated with chronic villitis, specifically with a pattern of brain injury that was predominant in the basal ganglia and thalamus. Fetal vascular malperfusion and chronic umbilical cord obstructive lesions, usually high grade with extensive avascular villi, found by a number of other investigators to be associated with neonatal encephalopathy at term, found in several studies to be associated with neuronal necrosis and stillborns, and with perinatal stroke in a study by Theonia Boyd at Children's Hospital in Boston. Thrombi per se, usually associated with acute chorioamnionitis. Again, neuronal necrosis in stillborns, seizures in preterms after preterm premature rupture of membranes associated with chorioamnionitis, periventricular hemorrhagic infarction by Peter Nichols, ventriculomegaly and abnormal MDI at 20 months in the Elgin Study by Jonathan Hecht in collaboration with Alan Leviton. Chorioamnionitis alone, associated with periventricular hemorrhagic infarction, early ultrasound abnormalities, neonatal encephalopathy at term, perinatal stroke, autism, epilepsy. Maternal vascular malperfusion, generally severe. Again, IUFDs with neuronal necrosis, periventricular hemorrhagic infarction, microcephaly, and autism. And then one study of massive perivillus fibrin deposition where they correlated it with abnormal head ultrasound and other neurodevelopmental abnormalities at 18 months. And that was Becky Bergen at Cornell. Diffuse villus edema, we've published the most about that, but also Marjorie Grafe associated that with neuronal necrosis in stillborns. Chronic abruption, we found that in one of our early studies, also found by Karen Nelson, just based on clinical vaginal bleeding in the first and second trimesters, and Marjorie Grafe found it in stillborns with neuronal necrosis. Theonia Boyd is also found an association of prolonged meconium-associated changes with neonatal encephalopathy, and then, as I mentioned before, this association of multiple placental lesions affecting different pathways with various types of CNS injury has been found to correlate with abnormal head ultrasound in preterms, neonatal encephalopathy with abnormal MRI findings, and perinatal stroke. And so the overall picture that I would paint of how the placenta interacts with CNS injury is that you enter this black box of pregnancy at implantation, and there are a number of things that happen in early placentation that set up your placental phenotype at about mid-trimester. There are environmental factors, there are genetic factors, and then there's just interactions between fetal and placental physiology. And what we would like to find are biomarkers which can identify which placentas are at risk so that we can increase the monitoring of those cases and possibly do some therapeutic interventions. That phenotype then sets you up. It's the chronic lesion that then sets you up, preconditions you for later injury And all of these things are affected by stressors that are usually exogenous, but may also be host-derived, and they act on this abnormal phenotype and cause this late placental state and interact to cause CNS injury. Penn has written extensively on things like placenta, and Nigel Paneth have talked about moieties in the placenta that may protect against CNS injury. Allopregnanolone and serotonin are just two examples. And these may mitigate CNS injury. And perhaps if we have disease biomarkers, there may be other therapeutic interventions that we can introduce. Essentially, and obviously postnatally head cooling would be one, but there may be prenatal interventions that can decrease the risk of CNS injury in these infants who are at risk.